Good evening. I'm Sarah Martin. I will be presenting a case study this evening for MSN 616C, care of the chronic and complex client practicum. Our case starts out with a patient presenting to the clinic today with an approximate 1-week history of having a cyst on his buttocks. He states that his girlfriend has been taking care of and looking at the area for the last week or so, and states that the cyst seems to vary in size from one day to the next. He arrives today as the pain and pressure has gotten so bad that he is having difficulty sitting, walking without significant pain. He states that he does occasionally drain, but not in large amounts. He has been applying Neosporin ointment to the area and taking ibuprofen with moderate relief of symptoms. He denies any chills, fever, or malaise, does not have rectal or scrotal pain. He has no outpatient medications on file, no allergies of any kind except for Benadryl. Review of systems: constitutional negative, HENT negative, cardiovascular denies chest pain, respiratory denies shortness of breath, GIGU negative, neuromuscular negative, skin, he has a boil to the buttock area that he is verbalizing, hematologic or lymphatic negative, endocrine immune allergic negative, and psychosocial behavioral negative. Physical exam reveals blood pressure of 118/78, pulse of 125, temperature of 98.1, weight 88 kilograms, and SpO2 98% on room air. Physical exam: constitutional, alert, well appearing, and normal affect. Skin: 3 by 5 centimeter cyst noted to the perirectal coccygeal area as raised. No advanced erythema or extensive redness noted to the surrounding tissues. Eyes, pupils are equal, round, reactive to light and accommodation, extraocular movements intact. ENT: normal ears, ear canals, tympanic membranes bilaterally, nose normal, normal nasal mucosa, no nasal drainage, normal oropharynx, teeth and gums. Chest exam, neck exam: supple, no thyroidomegaly, adenopathy or masses. Chest exam: chest normal appearance, CTA bilaterally, no rills, wheezes, bronchi, or rubs. Cardiac exam: normal cardiac exam with the exception of normal sinus tachycardia, sinus tachycardia with a rate of 125. No murmurs, rubs, or gallops. S1, S2 heard normally. No lower extremity edema noted bilaterally. Abdomen, soft, non-tender, no masses or hepatosplenomegaly. Lymphatics: no cervical, inguinal, or lymphadenopathy. Musculoskeletal: normal inspection, palpation, range of motion, strength, upper and lower extremities bilaterally. Neuropsych: alert and oriented ×2, memory intact, normal affect. Assessment and plan. Patient is suspected for a perirectal abscess with need for drainage. We will proceed forth with an IND. After a CBC, BMP and lactic acid are obtained due to the elevated pulse rate, but afebrile. We will start Keflex 500 milligrams, 1 tab 3 times a day for 10 days. And then we will give 1 gram of Rocephin IM today prior to discharge. Plan is for that Rocephin shot, Keflex 300 milligrams, 500 milligrams 3 times a day for 10 days, starting tomorrow. The procedure today of the IND with packing. Leave the dressing in place tonight. Remove all the dressings tomorrow and the packing. Do sitz bath with Epsom salt after removal of the dressings and packing twice a day. Ibuprofen 800 milligrams 3 times a day as needed for pain with food. Okay to take Tylenol 1000 milligrams 4 times a day as needed for pain without taking the Vicodin. Also, patient may take Vicodin 1 to 2 tablets every 4 hours as needed, but then would not be able to take the Tylenol. The patient will return 2 days after procedure to follow up with primary care provider. The procedure. The patient indications, the procedure is an excision and drainage of an inclusion cyst or perirectal abscess on the coccygeal or perirectal area with local anesthetic followed by wound care. Indications for the procedure is a new onset inclusion cyst or perirectal abscess located on the perirectal coccygeal area on the right gluteal cleft. Patient presents today for the above procedure. Inclusion cyst measures 5 centimeters in length by 3 centimeters in diameter, well localized with no evidence of local infection. The patient's pulse was elevated during the clinic visit, so laboratory studies were evaluated and ensured systemic infection was not present. All laboratory studies were reviewed prior to the procedure and were unremarkable. After describing the risks and benefits to the patient, to include but not limited to infection, bleeding, and reoccurrence and scarring, consent was obtained. Procedure in detail. Formal timeout was carried out. The patient was identified and positioned. The site was draped and prepped in the usual sterile fashion. Lidocaine and epinephrine solution was injected subcutaneously to achieve good local anesthetic effect. A15 blade was introduced to the area and incised the cyst. A Kelly clamp was utilized to deroof the cyst. Copious amounts of purulent, foul, odorous drainage was expelled from the wound until bloody drainage was noted. The underlying tissue was washed with aseptic solution of betadine and normal saline solution until clear. The wound was then packed with iodoform gauze, skin prep applied, and covered with dry dressings with excellent results. The patient was tolerated the procedure well without complications. The plan, again, is for the patient to have the shot of Rocephin today, 1 gram. Then he will start the Keflex 500 milligrams 3 times a day for 10 days starting tomorrow. He will keep the site clean and dry until tomorrow, when he'll remove the packing and perform sitz baths twice daily until a follow-up on Wednesday or in 2 days with his primary care provider. The patient will monitor for any signs. The patient was given instructions to strictly monitor for any signs and symptoms of infection, such as pain, swelling, warmth to the touch, foul drainage, or elevated temperature, chills, fever, or rigor. Patient understands and agrees with the plan of care. That's it.